Let's concentrate why when the patient exerts, patient gets chest pain. It will be answered. This question will be answered by pathogenesis. Remember that in case of stable angina, as the name suggests, right, there will be about 70% of occlusion of the coronary blood vessels. We are here with another fascinating topic, and that is ischemic heart disease, IHD. So before we do talk about the subtypes of ischemic heart disease, let me define what is exactly ischemic heart disease. So remember that all those group of disease that impair the blood supply to the myocardium is called ischemic heart disease. Remember that ischemic heart disease is a group of disease that can cause or disrupt blood supply to myocardium. So ischemic heart disease is not a single disease, it's a group of disease which disrupt blood supply towards myocardium. Ischemic heart disease is the most common cause of death in the US. All those risk factors that can cause atherosclerosis can also cause ischemic heart disease. So for risk factors, we can easily say age, your gender, your ethnicity, and diabetes mellitus, dyslipidemia, all those causes that can cause atherosclerosis that can also cause ischemic heart disease. Right. So now we have to go towards the subtypes of ischemic heart disease. These are basically a group of disease that can cause or disrupt the blood supply to the myocardium, hence can cause ischemic heart disease. It contains stable angina, unstable angina, vasospastic angina, myocardial infarction. Today we are going to discuss stable, unstable, and vasospastic angina. Myocardial infarction is a separate lecture itself. So let's start from stable angina. Let's take a typical scenario of stable angina. A patient comes to you, to your OPD, and says that, doc, whenever I exercise or whenever I run, I take some steps, I suddenly start to get chest pain. Whenever he presents with such a scenario, you can doubt that this might be stable angina. Now let's concentrate why when the patient exerts, patient gets chest pain. It will be answered. This question will be answered by pathogenesis. Remember that in case of stable angina, as the name suggests, right, there will be about 70% of occlusion of the coronary blood vessels. Now the question arises over here that why when the patient is resting, he doesn't get any chest pain, but the moment patient starts to exert, patient gets chest pain. So as you people can see over here that it's only 70% of obstruction seen in coronary vessels. So when the patient is resting, the coronary vessels are still 30% opened or non-occluded. So when the patient exerts, the mismatch occurs. We have found the answer that this is the mismatch that actually occurs. It means when the patient is resting, 70% vessel is occluded, but 30% still supplies your heart, your myocardium. But the moment patient exerts, this 30% non-occluded vessel is not enough to actually supply the nutrients, the key nutrients, the oxygen towards the myocardium. Hence the patient gets chest pain. This is the pathogenesis related with stable angina. Now let's talk about type of injury. Remember that cell injury is basically divided into two types of injuries, reversible and irreversible. Over here in case of stable angina, it's a reversible cell injury. It's a reversible injury. Now what does it mean to us? Clinically it means that if you do the troponins, which are basically cardiac biomarkers, these troponins will be absolutely normal. This is because this type of injury is reversible. It can be reversed. Hence if you do biomarkers for a patient with stable angina, biomarkers will be absolutely normal, and it actually differentiates it from myocardial infarction. How will the patient present? Patient will present with shortness of breath, right, diapaurosis, right, diapaurosis, and of course chest pain, as the name suggests, angina, chest pain. And remember, this chest pain will be radiating. radiating chest pain will be seen. Now on ECG, the question is on ECG, what will happen? On ECG, you people will have ST depression. You people will have ST depression. Now why you people will have ST depression? Because this type of ischemic heart disease, because the pathogenesis over here is subendocardial. Subendocardial portion is ischemic over here. Hence you people will have ST depression. Remember, whenever the impaired blood supply is involving subendocardial portion, you people will see ST depression on you. As you people saw that whenever patient rested, the symptoms subsided. This was just because of its pathogenesis, that it was involving 70% of blood vessels. Now as the patient rests, the chest pain will be relieved. Now let's talk about unstable angina. First let's take its typical scenario. Typical scenario will be the patient will be saying that I always have chest pain whether I am resting or I am exerting, or when I take some steps. Means he or she might be getting symptoms while exerting and while resting. Now let's talk about the pathogenesis of unstable angina. Remember, it's the rupture of atherosclerotic plaque. Remember, if this is an atherosclerotic plaque with fibrofatty cap, this atherosclerotic plaque might rupture, and this rupture might actually block the distal portion of the coronary vessel that can cause unstable angina. And if we talk about the type of injury, the type of injury over here is reversible too. So you people can easily guess that what will be the ECG finding in this unstable angina. It will be ST depression. And remember that this is not relieved by rest, but this can be relieved by nitrates. Why nitrates will actually relieves patient symptoms? Because you know the nitrates are venodilators. They are, remember, you people will actually hear it as vasodilator, but it's more specifically said to be venodilator, right? It's a venodilator. That's why as it's venodilator, the preload will be decreased. Hence with decreased preload, the myocardial oxygen demand will also be decreased with decreased preload. So that's why nitrates can relieve this patient's symptoms. Now let's talk about vasospastic angina. This is very different as compared to stable angina and unstable angina. Now let's talk about the pathogenesis of vasospastic angina. Remember, here in stable angina, we had a mismatch, like 70% of the coronary vessels were blocked. But in unstable angina, we had rupture of atherosclerotic plaque. But in vasospastic angina, you people will see that there is no mismatch or no atherosclerotic plaque rupture. But as the name suggests, there is vasospasm of smooth muscles lining your vessels. And remember, this vasospasm is usually transient. So when you do the ECG for these patients, you might find absolutely normal ECG. Absolutely normal ECG. The normal ECG is seen when there is no vasospasm taking place in the coronary vessels of patient, because we just said that as far as the pathogenesis is concerned, it is due to transient vasospasm of the coronary vessels. Now, what are the classic demographics for vasospastic angina? The classic demographics are women, who are smokers. This is actually the classic high yield point for USMLE step 1 and step 2 is that the patient with vasospastic angina will be women and will be smokers. Remember, this pain is relieved by nitrates and calcium channel blockers.